Well, good morning, everyone, and welcome to the budget hearings. Manager Stoltz, what do you have for us?
Good morning, Commission. This is it's a budget / operational meeting discussion here. We got ComCare staff on board to talk about the CCBHC model. Operationally, that's different, and from a revenue generating model, it is also different, which is why it ties to budget to some degree. So with that, I will turn it over to whoever. Tim, who do you want to talk first? Or?
Morning, Commissioners. Michelle Calvert, who is the Director of Quality and CCBHC for ComCare, is going to present. Kathy Wagner is here in case there are a lot of financial questions as well. So,
good.
Thanks, Michelle.
How's Joan doing?
She seems to be making progress, and she's in good spirits. So,
good. Thank you. Well, good morning.
Good morning. I'm Michelle Calvert. I'm the Director of Quality and CCBHC at ComCare. Let's see. Okay. So we're going to be focusing today on looking at what a CCBHC is. Not only that, but what are the scope of services that are a part of it, the evidence-based practice that go into it, and then also look at cost reporting and how the cost changes from the previous payment model to a new payment model as part of a CCBHC. So looking at CCBHC and just getting a good understanding of what it is, it's not something horribly new to behavioral health. However, SAMHSA, I guess if you look at the broad scope of history of behavioral health, CCBHC is actually incredibly new. But SAMHSA is the Substance Abuse and Mental Health Administration, and it is a federal program. SAMHSA really guides all mental health and behavioral health treatment in our country. So this is a SAMHSA design model, and the intent of it really is to provide comprehensive mental health care. So in the past, we've seen mental health care really focusing on mental health only. In a CCBHC, the way that it changes is that the focus moves more towards mental health and physical health being so closely connected. Along with becoming a CCBHC, we see the payment model change. So as a Medicaid provider, there really hasn't been any Medicaid adjustment in payment since I think 2007, the last Medicaid reimbursement increase. As a CCBHC, the payment model completely changes. So it moves more towards a cost basis. So we'll see what that looks like for us. To give you a bit of a history of CCBHCs, it really started in 2014 when SAMHSA developed these demonstration grants. So in 2014, 8 states applied to become CCBHCs. It has grown significantly since then. So 2015, CCBHCs were in 24 states, and then now we have over 430 CCBHCs in 42 states. So you can see how it has grown, but in Kansas in particular, this is really important and also really exciting. So we know that insufficient funding has been a pretty significant barrier to providing mental health treatment with access to care. Medicaid just doesn't really take into account the full level of cost for providing services. And I want to reiterate here, this bottom paragraph is just like stars. It's a huge deal. In 2021, Governor Kelly signed legislation, and that legislation made Kansas a CCBHC state. So what she did with that legislation is that it determined that the CCBHC model of care is the gold standard for our state. We are the first state to do this. This is so incredible. And not only are we the first state to do this, it didn't just pass minimally, it passed with flying colors. 160 of 165 legislators approved this. So it's just really incredible to think of how many different legislative things pass at that level. So this is really amazing. So in May 1, as of May 1, there are 6 centers that will be CCBHCs, and that will progress. So in July of 2023, there will be 9, and then July of 2024, there will be 8 more. So you know us as ComCare as a community mental health center, so CMHC. That will not change. We will remain a CMHC, and then we also have certification as a CCBHC. So the certification for both of those line up nicely. The state is who provides that certification. So it's important to note that we will not lose that CMHC status. Okay. So looking at what a CCBHC looks like kind of after the fact, and then what things were like before we became a CCBHC. In 1990, mental health reform moved towards community-based services, which is excellent. Providing services in the community is where they need to be at. However, the service cost was greater than the reimbursement rate. So that's pretty significant. In moving towards a CCBHC, we moved more towards a new rate of pay for those services. So we get reimbursed more on a cost basis. So that cost basis is pretty significant for us because it will just really impact the organization overall and our ability to hopefully pay our staff the level of pay that they really need to provide the services that our community needs. So CCBHC is a very patient-centered approach. We want to be out in the community, providing services in the schools, in the home, in the workplace, and that's the intent of CCBHC. There are several program requirements as part of a CCBHC. There's a lot of reporting, so we gather a lot of data on our patients, and that data allows us to see if a patient is progressing or not progressing, and then it also helps guide movement to where we need to go. It helps us identify areas of improvement as well. Availability and accessibility of services. The whole goal of CCBHC is to get somebody served as soon as possible. We want to be able to meet patients where they're at as soon as we can so that we can help eliminate mental health symptoms worsening. There's organizational authority. So as a CMHC, we have a mental health advisory board, which you all have appointed folks to. As a CCBHC, we have a CCBHC advisory board. Our previous advisory board will remain. This is an additional advisory board. And this advisory board is made up of 51% individuals who have lived experience, family members in services, or some sort of shared mental health experience. Okay. We'll look at the scope of services here shortly. Care coordination is a significant part of CCBHCs, and we'll look at that here too. But then most importantly, we need to have the staff to provide the services that a CCBHC requires.
Maybe I'm jumping ahead. Do the commission appoint this new board?
The old board, the Mental Health Advisory Board. So what we did for
The
our
Mental Health
new...
Advisory Board appoints the new CCBHC
So the
board?
CCBHC Advisory Board was selected based on individuals who are already in services. We have community members, we have NAMI representatives. We kind of have a broad range of folks on that.
Okay, thank you.
So, Michelle, the 51% is people with lived experience, but what's the other 49%?
So there's a 51% expectation. So
Okay.
you have to have at least 51%. We actually have more. 4 out of 5 of the folks on our advisory board do have shared lived experience, either themselves or with family members.
So the total board makeup is 5 people?
Currently, yeah.
Okay.
I'd like to be at 7, but we'll get there.
Okay, thank you.
Yep.
Oh, while we're pause for just a minute, if the governor signed this in 2021 and we knew about it, why did we have on our legislative agenda, this is one of our top items, was pay reimbursement rates? If this was a possibility that the governor signed into effect in 2021.
So not all of the services that ComCare will deliver going forward are CCBHC services. Some of them will still be paid under the old Medicaid fee-for-service model, and not all of the CMHCs across the state are at CCBHC level yet. So it was important to see that 4% increase for mental health services across the state and going forward for ComCare for those non-CCBHC services.
Okay, and if this was signed in 2021, is this the soonest that we could start implementing this, or?
Yeah, Michelle's going to get into kind of the process that it took to get to that decision by the governor and where we're at today.
Okay, sorry to interrupt you.
No problem at all. And the legislation actually required 6 CCBHCs to become, or 6 centers to become CCBHCs this year. So May 1 is really where that started of this year. So looking at the scope of services that are required as part of a CCBHC, you can see a listing of them here. The blue services are services that ComCare already had prior to becoming a CCBHC. So 24/7 mobile crisis team services, we're pretty proud of these. We have some really incredible mobile crisis teams in place. And I will say that this one in particular is a pretty heavy lift for other centers across the state. We were able to put those into place long before becoming a CCBHC, so we really were ahead of the curve, which is pretty awesome. Immediate screening and risk assessment, commitment to peers and family, so having staff who are peer support, and then having a strong focus on educating family members about mental health. Patient-centered treatment planning has been a core expectation for us for many, many years. That easy access to care, we've had open access clinics at several of our locations, and the reason this isn't blue is because this is something we know that we need to really increase and expand upon. That took quite a heavy hit with COVID. Care for active duty military and veterans. There's a strong emphasis on veteran care as a CCBHC. Expanded care coordination. So those three there on the bottom are ones that we're really focusing strongly on. But I do want to reiterate that we already had a lot of services in place prior to becoming a CCBHC.
So what do we do with the active duty? Because military should be taking care of their own.
Exactly. So I will say this has been one of the more difficult areas to expand upon, especially because we have the VA here in Sedgwick County. They do take care of their own, and we've been working hard to develop some care coordination agreements with the VA. We do have the ability to serve veterans and their family members, but yeah, that has been a struggle for us to expand
Well,
there.
the VA takes care of the veterans. I'm interested where you've got the active duty military, because
Right.
like at McConnell, they should be taking care of their own out of McConnell. How much interface do you have with McConnell to do something?
I'd say very minimal.
That's what I thought.
Yeah.
And Chairman, one of the reminders is that this is a nationwide implementation, and we know that there's rural parts of every state across the country where they don't have access to the VA. They may not have access to bases that way. So that's one of the reasons it's a requirement. It's a national requirement. We're lucky in this community because we've got the VA that we can work with, and we can coordinate services with McConnell as well.
But the VA really doesn't do much for the active duty. That's the area that I was kind of interested in.
Mr. Chairman, just met the other, earlier last week, the lady that's in charge of the mental health support stuff for McConnell at one of the meetings, and it was a very impressive lady, so I'd be glad to find her name and contact, and you can visit with her. But
Well, the VA does a great job. I'm sold on the VA here. I just don't know what we can do to help the active duty side.
Yeah, I agree. It's definitely something that we need to expand upon for us as well. I will say one of the struggles with that is that it takes a specific license in order to provide the care to the insurance for veterans, and our level of staffing is low enough that we don't have as many staff who are at that level of licensure. So that's a struggle for us. We would like to definitely expand that for sure. So moving on from scope of services, unless you have any more questions. Okay. We have a heavy focus on increasing our suicide risk assessment, training, collaborative care, and those are things that we'll talk more about here too. So looking at who's served by a CCBHC, CCBHCs are intended to serve any individual in need when they need it. So crisis center is imperative for a CCBHC along with the other services that we talked about. We're working with adults with serious mental illness, youth with serious emotional disturbance, individuals who have mild to moderate mental illness, substance use disorders, and then those with complex health profiles, because we know that mental health is definitely a part of having a complex health profile. We want to provide care regardless of the ability to pay. So we all know that ComCare tends to be the safety net for Sedgwick County when it comes to serving those who are underserved, under or uninsured. That does not change. We will continue to be that, and we intend to serve patients where they are at. So that's something that we've always done, but continue to do as well. So we want to, again, be in the community with our patients, serve them in the schools and the workplace, wherever they are at, so that we can help them be successful. Our intent really is to serve people in the community. And we want to divert from any crisis level of care as much as possible, because we know that people function in their community, not necessarily in crisis. Okay? The state has identified 4 core evidence-based practices as part of CCBHC. There's medication-assisted treatment, known as MAT. So medication-assisted treatment is medication in combination with behavioral health care for individuals who have substance use issues. Cognitive behavioral therapy has been a tenet of mental health services. Typically, everybody who goes to school learns about CBT, and this is something that we expand upon. CBT is really a focus on identifying negative thought patterns and understanding how thought patterns influence behavior and emotions. Supported employment, and the state has chosen IPS for this. We were an IPS provider in the past, and we will move more towards that in the future as well. IPS is focusing on helping folks find success in their employment. And then assertive community treatment. This is a really exciting one for us. So assertive community treatment, or ACT, is a service model that really helps individuals who have extensive mental health issues. So these are folks who have, like I said, significant psychiatric issues. They struggle in the community. They may be hospitalized regularly. They may have a lot of contact with the justice system as well. So ACT model of care is a whole treatment model, which we'll talk more extensively about. Yes.
So if we can implement this mental health court in our court system, will that help with this last step?
So we already work in mental health court as part of ComCare. There is some transitioning between mental health court and services that we provide. So there may be folks who transition from mental health court into the ACT treatment team. So yes, definitely. We want to be available in the court system as much as possible.
So that's another reason to talk to Dr. Goering, or Judge Goering, about implementing the mental health in the veterans courts here.
Okay. So looking at ACT in depth is one of the most widely researched evidence-based practices in mental health care. It is a multidisciplinary team approach. So that's really what I want to stand out here, that multidisciplinary team. It has been shown to reduce hospitalization, increase housing stability, and really just increase individuals' level of care significantly. We have found that on our ACT team, our team has reported greater satisfaction with employment. They feel safer going out in the community. They feel more effective as a team. So we've seen some really good results with our ACT team. Now that team consists of a team leader, a clinician, somebody who's able to treat substance use issues. We have a team of integrated care specialists, an employment specialist, and also housing specialists on our team. So again, these services are intended to be provided in the community. So we go to the patient as much as possible. And then rather than that patient having one individual treatment provider, they have that team. So if I'm working with somebody and I have to be out for an extended period of time, they already know who their treatment team is. So there's not that transition of care because it's a team model. So that's the strength of an ACT team. And then those individuals also receive services more frequently. Services are not time limited. So they receive as many services as they need for as long as they need. Moving from ACT team, a strong piece of CCBHC's is care coordination. And this is one area that we want to really expand upon within ComCare. The main goal of care coordination is really to meet a patient's whole health needs. So care coordination really starts when somebody walks in the door. So if someone walks in the door and they come to us for services, we want to connect with who their primary care physician is. We want to coordinate with the hospital. We want to coordinate with their therapist. We want to coordinate with their case management team, their med provider, the MCO. We want all of those teams working together for the success of this individual. It is a highly collaborative approach. So that's an area that we really intend to expand upon here. With that strong focus on behavioral health and physical health being so closely connected, this is imperative. And we've moved towards gathering height, weight, blood pressure for our patients so we can help impact their physical health needs. So there are some reported measures that we focus on. So we talked a little bit about access to care. So the intent for access to care really is to make sure we're getting patients in within 10 business days. I will say we are able to get patients in quicker than 10 business days on average overall, but we always want to expand that. We would like people to be seen immediately. So when they recognize that they want to get into treatment, that's the time to get them into treatment immediately. So there's one reported measure. There's a huge focus on preventative care and screening, so that's where we're gathering the height, weight, blood pressure, waist circumference. We're focusing on tobacco use, unhealthy alcohol use, asking those questions and also providing some intervention immediately. We're assessing for major depressive disorder ongoing, so we're doing suicide risk assessment, and then also what's called a patient health questionnaire, so PHQ-9, to assess for depression levels. So that's something that we've been increasing significantly over the past year as well. So we've done over 3,000 assessments when it comes to PHQ-9 and depression. That gives you an idea of just how many we're really focusing on doing. So we've talked about what a CCBHC looks like, why it's impactful to the community, but let's move into the change in payment rate for what that looks like. So in order to determine what an appropriate model of pay would be, we did a very extensive cost report. I know there's a lot of words on the screen, but bear with me. So we did this extensive cost report, and what we did with that is we looked at 2020 expenses. So during that time, we looked at all of the services we provided and then the cost of providing all of those services. Do math, and then we determined the cost that it takes to provide services every day. Now, in this initial cost report, we were able to look at anticipated costs as well. So we're able to look at market adjustments, salary adjustments, and take all of that into consideration up front. So this is why it's so important for us to really take a close look at those market adjustments as soon as possible so we can make sure that our cost reporting is correct as we move forward as a CCBHC. So we come up with that initial cost rate, which we'll get to. We know that in 2023, we will be able to kind of redo that math, do a new cost report, and determine if we're on the right track. So this is one of the things that's great about CCBHCs is that you have the opportunity to rebase off and on. Whereas before, we didn't have a Medicaid increase since 2007. Now we'll be able to look at it more regularly to make sure we're on track. So for the rebasing, that's an opportunity. So again, we need to elevate our expenditures to make sure that we're at the right level moving forward as a CCBHC. And I do want to point out that in the future, all cost reports will not be able to take into account anticipated costs. They will be actual costs. So within this new payment model, the way we get paid is that we have a trigger code. So the state determined that we go through a PPS1 rate is what it's called, and it's a daily rate of service. So what we're looking at is the cost it takes to provide a service every day. So the rate that was determined was $245 per patient per day. The way that that rate is triggered is twofold. A patient has to have Medicaid, and they have to be provided one of those CCBHC trigger codes. And we'll look at those codes here momentarily. But just to give you an example of what this looks like, if a patient sees their psychiatrist in a day, in our previous payment system, they would see their psychiatrist and we would get paid $90 for that service. In this new system, they see their psychiatrist and we get paid $245 for the day. Now that same patient might see their psychiatrist in a day, they might see their therapist in a day, they might see their case manager all in the same day. The rate is still $245, so it's a daily rate as opposed to a service fee. Does that make sense, the difference? Okay. So there will be times when our costs are not covered, but the rate is designed to look at the overall costs. So these are the trigger codes that trigger that $245 rate per day. So the dark bold services are the ones that we provide the most. So those are really core tenets of our services. Those blue services are services that we are expanding upon as a CCBHC. The other ones, of course, are services that we provide, but I wanted to give you a nice picture of what we provide the most of and then where we're expanding in. There are a few services that do not trigger the daily rate. And those services in particular are psychosocial rehabilitation, attendant care, all waiver services. So waiver services are services that are designed for youth who may be at risk of state hospitalization. One Care Kansas services, and then also inpatient consultations of our psychiatrist within the hospitals. Okay. So let's look at revenue projections and what that looks like for us. So we did a revenue projection based on 2020 services that were provided. So in 2020, we provided 131,000 trigger code services, so the services that we just looked at. We were reimbursed. The revenue was $8.8 million there at the bottom. Had we have been paid on the CCBHC model, it would have been or could have been up to $22 million. So it's a significant difference. Okay. If we look at what the data is saying so far, these are actual numbers. So CCBHC began May 1. That new payment rate began May 1. So we took 2 weeks of data, because we're still in May, and looked at what it really looks like. So in 14 days, the Medicaid fee-for-service, if we were getting paid the previous model, would be $364,000, and then the new CCBHC revenue will be $687,000, which is an 88% increase. With looking at the timeline for CCBHCs, this will kind of speak to the question that you had about when it was signed into legislation. February 2021, we received a SAMHSA grant, and that SAMHSA grant was designed to help us move towards getting everything in place to become a CCBHC. So there is a significant amount of criteria, lots of check boxes. So that grant was designed to check those boxes off. In January of 2022, we submitted that extensive cost report to the state. February 2022, we submitted our application to the state to become a CCBHC. And then in March, we received that provisional certification, and we are live as a CCBHC as of May 1. This timeline doesn't look super extensive, but I want to reiterate that in all the years that I've been doing behavioral health, I've never seen such collaboration as this. We are coordinating with the state, with the Association of Community Mental Health Centers, so KDADS, KDHE, the association, and the National Council for Mental Wellbeing. Like I said before, Kansas is the first state to do this. This is being nationally looked at as one of the leading community mental health centers in Kansas and now one of the leading CCBHCs. This is really cool. I mean, this is life-changing. So it's amazing. You know, this is an opportunity for us really to expand our services, expand our staffing, and with that, we can have a great impact on this community in general. So looking overall, the goal of CCBHC is really to provide whole health care. Mental health, behavioral health being so closely connected, we have an opportunity to make an impact. We increase our training, we increase our impact within the community, we train community members, we train our staff. This is the focus of CCBHC, and really hit as many people as we possibly can, especially right now when we see mental health needs going up so much within our community. This is imperative. The service array is deliberate. We want to create access. We want to stabilize people. And there's this huge focus on recovery, wellness, trauma-informed care overall, and just that close connection for physical and behavioral health. You know, for folks who are just now starting in the mental health field, this is the time, this is the place. You know, this is where people need to be when they're just now getting into the field, because they can grow just a wealth of experience. So we have an opportunity to hire as many people as possible. This is the forefront of behavioral health. This is cool. I mean, it's epic. So what questions do you have for me?
Well, first of all, thank you. I must have been living under a rock recently because I wasn't aware that this was going on. So
It's so cool.
I apologize for not knowing that. We're going to have additional revenue starting immediately with your briefing. So with that additional revenue that we've got immediately, and we're 200 short in ComCare right now, are we able to then transfer that revenue immediately to start providing the raises that we need in order to start hiring more ComCare folks?
Good morning. We are actively working with ComCare, Kathy and her staff, to go through different comparables and what we'd be able to adjust positions to. We're waiting on a final spreadsheet from ComCare. So to answer your question, no, we haven't implemented anything yet, but we are getting very, very close.
Okay, well, I hope that we don't just put it in the general fund and We need to roll it back into the people that are providing the services so that we can hire the people we need in order to provide those services. All right, Lindsay, are you going to tell me we can do this?
Yes, it is all going to stay in the comp care revenue fund. None of this will come into the general fund.
While you're there, Lindsay, and I don't want to interrupt you, Chairman, but when ComCare presented their budget, they're asking for, there was a decision package in there. Can you talk on that for just a bit?
So there were a few that were presented. There was the workforce development, there was the market pay, and then there was security. And so the security isn't really a part of this conversation. But those other two, I think there was a ballpark figure of 4 million for market adjustments without really knowing yet exactly how that would be implemented. And I think that's what Sheena was referencing. So that's one of those that can happen. And then the other item was, it's not so much tuition reimbursement as much as it would be funding folks who currently have a bachelor's to go to school to get their master's, and it can be several, as I understand it, depending on their track that they want to do. And so the proposal would be to pay for that tuition over a 1 or 2 year term, so that, and then obviously with an agreement, hopefully for those staff to remain with us for some period of time, so that ComCare can kind of grow its own folks who can help get those billed services. So if I've misspoken about anything, okay.
Good. One final question. Were you available to brief the Mental Health Substance Abuse Coalition? Because I don't know that they're aware of this. Were you aware of this?
Yeah, I've been aware of this.
Okay.
Yeah. Joan's been talking about it for a while.
She's been working
Not
really,
the
really
fact that
closely
we're
with
getting
everybody
this
on it.
type of a revenue from what we're doing.
Yeah, she's been talking about it the whole time.
You know, in all fairness, we knew that the cost would be a difference, but it's really more recent where we've been able to determine what that cost would be and move towards implementing that.
Okay. Other questions?
I have a few.
Sure.
Thank you, Michelle, for being here today. As a part of the ACT team, how do we plan to incorporate those that are kind of specialists in this space already? So, housing specialist, we have a whole city department that's fully housing specialist. We have a employment specialist with all of our, what's the place over there on? Yes, thank you. Workforce Alliance, substance use with SAC. Like, how do we plan to incorporate so that we aren't doing all of this when we have specialists in the community that are able to?
Yeah, we don't want to duplicate care, but at the same time, we have some specialists within that ACT team as well who have some very specific training in order to work with individuals with severe mental illness as well. Not to say that others don't have that training, but to have those in-house as well will be really important, and they're going to help collaborate with those organizations outside of here. So this is where that care coordination is such an important piece of CCBHC. So like I said, we don't want to duplicate care, but we definitely want to connect people to the care that they need. You know, ultimately the goal is not necessarily for someone to be in services forever. We want to connect them to the community members who can help meet their need as they're kind of moving along through life.
So, and then with this team, is there one point of contact for the person, or will the person have, you know, the patient, how does the patient navigate this? I mean, how can you really keep track of?
So what we've been doing for the most part is they have a whole team approach. Their integrated care specialist will be their primary point of contact, but they're going to be working with that integrated care specialist along with other team members, so they will know and have multiple numbers for who they can contact. So they may contact one person today and another person tomorrow, but that treatment team is meeting daily to go through every single person on the caseload. So they meet and say, hey, what does this person need today? And they cover the entire caseload before they go out into the community to work with them. That way everybody's on the same page.
Okay, thanks.
Commissioner Howell.
Thank you, Mr. Chairman. Thanks for briefing us this morning. I had to go look up the bill number. It's House Bill 2208.
Correct.
From 2019. I haven't had a chance to look at the fiscal note on that yet, but is this funding for this coming from state?
It is.
State revenues, not federal pass-through?
Tim looks like he wants to talk.
It's Medicaid dollars, and so it's that blend. I think right now it's about 60/40.
60/40, okay. I hate to say I'm a little bit confused, but it sounds to me like we were we were not one of the 42 states originally.
We were not.
And so we come in from being not one of the 42 to being one of the, I guess, 43rd state, if you want to think of it that way. And at the same time, a lot of these CMHCs are becoming CCBHCs, 26 of them total between now and 2024. Am I
Correct.
right so far? Mm-hmm. And you said they were the first in the nation to do, what specifically are we first at?
So this is we're the first state in the nation to sign CCBHC legislation.
I see it says we identify as a CCBHC state.
So other states have identified, or other states have had centers within their state that have become CCBHCs. We're the first state to sign legislation that identifies CCBHC as that premier model of care. So there's significant coordination and collaboration between the state entities and the association in order to move towards CCBHC. And I will say that not only are we the first state to do this, we've done this faster than any other state without the same level of federal funding that the other states had. It's remarkable.
Okay, so the primary thing is we've identified the CCBHC model as our preferred, if you will, way to provide mental health services in a community.
Which helped pave the way for that CCBHC payment model as well.
Okay. All right. And a fiscal note on this. So this is a pretty big change for our state, obviously. What's the impact on the county? What's our county's obligation change as a consequence of going from CMHC to CCBHC here in Sedgwick County? What's our cost change going to be?
I'll let you answer that one.
The most significant change would be in the event that we are able to develop a new payment plan for ComCare to be able to attract and retain staff to deliver these services. There are about 10%, 12% of the ComCare positions are in the general fund rather than in the revenue fund, and so there may be some financial obligation tied to that pay. We haven't calculated that yet. We're still working with Sheena and finance to get that figured out.
Okay. Michelle, as you were reading, excuse me, I think as you were reading, which slide was it? Yeah, slide 3. You talked about mental health and substance abuse, but you used the word physical health when you read that. And I see over on another slide, we talk about things like body mass index and tobacco use. Those are things that are going to be part of this CCBHC program that are not really related to mental health directly. There may be issues in that person's life, but if someone has a tobacco use concern or problem, can they access services through CCBHCs if that's the only issue they're dealing with?
We have tobacco cessation services available, yes. And I will say, looking at tobacco, it can very well be connected to mental health as well, because looking at people may start smoking tobacco, but then they start using it as a way to reduce anxiety or a way to not eat as much. I mean, there are so many things associated with tobacco use as well that are very closely connected to mental health. So we do have the ability to serve somebody who comes in saying, I want to quit smoking.
I guess what I'm asking is, if someone's not been diagnosed with a mental illness, okay, and they want to access these services, and the only thing they're dealing with is a physical health problem, let's say they have a BMI that's too high, and they want to lose some weight, okay, and they've not been diagnosed with mental illness, are they going to be able to come to our CCBHC and get services from this organization?
So what we would do for that individual is we would work with them closely and really collaborate and connect them to probably physical health care needs. So we would maybe work with them to get them to a primary care physician. We would work with them to make sure that they're connected to their managed care organization so they know what they need or what's available to them. And then if they had mental health needs associated with that, we would work on that collaboratively. We would like to work with somebody who's in that process because that's a stressful process to kind of help them move along. So if somebody comes into us with only a physical health issue, we're going to be looking at if there are mental health issues as well. So CCBHC is designed for those two to be kind of interlinked together, and we treat the mental health side and then help impact that physical health side. So if it's only physical health and there's no mental health issues, we will connect them to a physical health provider.
Okay. Well, I agree with Commissioner Dennis. A lot of these conversations probably happen at the Mental Health Coalition, I'm guessing, because that's behind closed doors and I don't have access to that. So these conversations happen kind of in private, and I have no idea some of the things that have been discussed and some of the decisions that have been made.
I'd be
fact,
happy
me-
to provide any additional information
What's that?
if you have questions going
Okay.
forward.
Well, there's a lot to take in, and
Yeah.
I have to go back
It
and read
is.
this very carefully. One of the things I would like to ask is, sounds like we don't really have a choice going from a CMHC to a CCBHC. That choice has been made for us by Kansas, is that correct?
We still remain a CMHC.
I know we are. But I guess what I'm saying, with the choice to apply to get certified through the CCBHC program, that decision's been made already, and the question is, who made that decision?
The department did.
So every CMHC in the state of Kansas will be applying for
That's-
CCMHC.
Yeah, that's kind of the foundation of that legislative act. When Kansas said we're going to be a CCBHC state, the intent is to make sure that every CMHC in the state becomes certified as a CCBHC. ComCare probably further along than any other state in terms of that certification process, so it made sense for them to go first. But there is a goal to get every CMHC in the state certified as a CCBHC at some point in time.
And can I add to that too, that we had already applied for the SAMHSA grant to become a CCBHC before that legislation was in place. The Association of Community Mental Health Center executive directors have been working closely with the state to move in that direction for some time because it is such a benefit to the community and to the CMHCs in general.
Can you talk a little bit more about the 24/7 mobile crisis team services?
So we have a couple different options when it comes to mobile crisis services. We have ICT-1, which is that mobile crisis team that is the law enforcement officer, the EMT, and the social worker that are out in the community. We really want to expand that as much as possible. We also have mobile crisis teams, which is a clinician and a case manager who are available to go out into the community. Again, that's based on our ability to staff that. But we recognize the need and definitely want to expand those as well.
And that, for that part of it, the last part of that you just described, how do you get dispatched? I mean, do you get a call from 911, or how do you
Yes.
get dispatched?
So we may get a call from 911. We may get a call from a community member or somebody who's concerned. They would call our crisis center, or 911 would connect with us, and then we would determine how we can get to that individual.
I'd like to see some performance measures on that part of this program. I think that's, we talked about ICT-1 a lot in the last few years, and this was not part of the conversation, which I went to the Mental Health Coalition meeting you had the other day at WSU, and I was surprised to find out this is an ongoing program. How long has this been going on?
So our mobile crisis clinicians,
Yes.
oh gosh, I don't know what year exactly that started, but I could tell you specifically that during our certification process for CCBHCs, our number of outreach for mobile crisis did expand significantly, and I could share that data. I just don't have it right in front of me.
I think this ought to be a priority for our strategy for this community, and I assume that you guys will go county-wide. If you have a call
Yes.
outside the city of Wichita, you'll respond to that. Okay, and then I guess I'd like to know more about that, performance measures. I'd like to know more about the number of calls and that type of thing.
Okay, we can
To
play
me,
that.
one of the things you said the other day was only 2% of the time you guys have a need for a LEO on those calls. And that was very interesting, because I think ICT-1 takes a different tact. So
Yes.
maybe the right answer is somewhere between those 2 points, is I'm just going to say that. I know, Chairman, you're anxious to go move on, so I have more questions, but I'll stop for now.
I'm happy to answer anytime.
One follow-up on the mobile, are you using POVs or Sedgwick County vehicles?
Well, Sedgwick County vehicles for our, that's the right answer, right? For sure. Yeah, Sedgwick County vehicles are what we're using when we go out on mobile crisis calls, and then our ICT-1 has a vehicle assigned specifically to it.
If we were in a situation, and in the past we have been, where we've had multiple mobile crisis calls, and we had enough staff to respond to, say, 3 or 4 at one time, then maybe one of those teams may be out in their private car. But we've got a couple of vans that we use primarily for mobile
Yeah, well,
response.
I think the private cars are a liability to us, and I think it's a bad idea. So I want to make sure that we have Sedgwick County vehicles if we've got a dedicated mobile team to go out. Commissioner Meister, you had a question?
Yeah, just a couple real quick. Michelle, thank you for the presentation, and my compliments. You do a really nice job of presenting. And so Commissioner Howell, you saved me a conversation later. I was going to ask if you'd looked up what the House bill. So you mentioned that. So that's good to know. And I was impressed that you said in your presentation this passed 160 out of 165 votes.
It did.
So for Commissioner Howell, I don't know more background, but was impressive numbers when you said that. The other thing is so you did a analysis on 2020, and it more than doubled, 8 million to 22 million, but just in 14 days, it's just less than double. So early prognosis is
It's good.
significant. So did the reason that the feds or the state or whatever, this CCBHC model and the cost reimbursement, was it the physical component matching into that? Is that why? Was that the key component that made this whole program happen?
I'll take a shot at that. One of the reasons this model makes sense for behavioral health is the cost basis reimbursement is the model that they've used for FQHCs. So the federally qualified health centers have been on a cost-based reimbursement model for years. And it's successful for them. It allows them to expand programs, build buildings, and deliver services. And it was clear that the mental health system needed an infusion of money to be able to deliver additional services. And this is a great way to do it, changing to this funding model.
Okay, thanks for the explanation, and thank you again, Michelle.
Sure.
Thank you. Commissioner Cruz had a follow-up.
So, can we talk about outcomes for a second? So, where is the $200? Where did that come from?
The
How was-
$245.
The $245. Where was that?
So it's an incredibly extensive spreadsheet, but ultimately where that comes into play is it looks at all the services we provide, not just these CCBHC related services. So all the services that we provide as a CMHC and the total cost to provide those services. So it's kind of a division of one of the other, and then you come to this rate per day. This is what it costs us per day to provide all of these services.
So, how are you tracking outcomes?
So outcomes in particular are several of those things that we talked about before. So when somebody comes in as part of the CCBHC, we're doing this pretty extensive questionnaire that's asking a lot of different questions. And then we are gauging that kind of throughout treatment and then at the end of treatment. So we're able to see the progress that they've made, or as we're going, the lack of progress, and then kind of pivot to make sure that we're hitting progress in the right place. But it being such a person-centered level of care helps us move towards kind of keeping an eye constantly on the outcomes for each patient. Does that move towards the question that you're asking?
Well, Tim, you might help me, or somebody. I know that, is it a managed care organization or a federally qualified healthcare center? They get incentivized for their outcomes. So what is the incentive for us and this model to ensure that we are caring for the person? And I don't want to insinuate that you guys
Yes,
aren't
of
caring for
course.
people, because I know that you are. But let's say worst case scenario, you could get people through the day and each one of those codes is billed at $245. So what is the incentive to really treat the person so that you're just not billing for codes, but you're managing your outcomes to know how people are getting better?
Right. So for clarity with that, the 245 isn't per service, it's just per day.
Right.
So I do see what you're asking, though. I do understand that. So in having that rate, our staff are more able to, instead of move towards looking at, we need to build this number of services, they move towards, what do we provide that patient? What is their specific need? And then they can focus heavily on that patient's need, because we know we're going to be reimbursed at a rate that's appropriate for that. So it can change the outlook of the way that staff are providing services as well, so that they have the opportunity to focus more wholeheartedly on their patient and provide that patient level care.
So quality of care is the carrot, and recertification is the stick. So they are heavily regulated. They'll be reevaluated every 2 years, be recertified every 2 years. They're relicensed every 2 years, and those licensing and certification visits will be combined. But there are monthly reporting requirements on a CMHC that go to the state. Those things will continue, and then there's some additional reporting requirements. So there's a carrot and a stick. I think the carrot is probably more effective because the staff that work in this field want to help people improve. This gives them a better opportunity to do that, but there's also a carrot, or there's also a stick involved.
So do you have, with our old model, how are you reporting out your outcomes? Is that something that we could see? You saw X number of patients, their visit times decreased by, or I don't know what your measure is, I'm kind of just making this up, but is there
Sure.
something
We
that
can
you
give
could?
we can get you some samples of the
Okay.
data that we collect
Yeah,
and
definitely.
report.
I appreciate
And
that.
we've, as we've moved towards becoming a CCBHC, as soon as we got the grant, we were expected to provide outcomes regularly, every quarter. So we have been looking at those outcomes quarterly over the past year. So I do have those available as well. So I think that might help answer some of those questions too.
Okay, and just one last question. The housing component of this is just diving into all of the different funding availabilities that are out there. Housing is pretty complicated, as I'm
is.
sure all of
Yeah.
this is very complicated.
Yes.
But I guess that's my one biggest challenge is when we talk about coordination of care throughout this city, when we talk about the folks that are utilizing all of these services from Grace Med to Hunter Health to ComCare to every single medical resource, the drop-in center at Open Door, our homeless shelters, like these are such complicated programs that when we talk about really being able to help that person and having a specialist here and a specialist there, how do you determine, are you going to work with the city? I guess let's have a sidebar about that because I'd like to really
Yeah.
dive into some of this because housing is so critical right now.
Definitely. So we do have care coordination agreement with all the organizations you just mentioned with the intent of really having that collaborative care. But I mean, you're absolutely right. There are a lot of resources in the community, and as part of housing, we want to make sure that we're connecting to those different resources. We did have a very successful IPS program in the past. And then the funding kind of dried up for that and it disappeared. Now we have the opportunity to bring that forward, and the state is requiring IPS as that specific delivery model. So in order to do IPS and ACT, you have to do it true to fidelity, and the state is monitoring that. So they will make sure that we're doing that to fidelity as well. So there's an additional piece of it.
Okay, thank you for being here today. I appreciate your
Definitely.
time.
Thank you, Commissioner Lopez.
Thank you. I remember when I first came into this role talking to Joan about just this, and I didn't realize how much more revenue would be coming in from this. So I just want to give you guys all the kudos for all the work that you guys have done to get this implemented and so quickly. I mean, this is incredible. But when we were talking about FQHCs and their funding, modeling, and how that works, so I sit on the board at Health Corps, and so I know that the way they're able to provide services to people who are uninsured is that they'll have someone come in, and for each provider they see on that visit, even if it's in the same day, they get the $245 or however much it is for each provider and each different service. So is that something that potentially this could get to so it is more in line with the FQHCs, or is there a way that we could push that? So if we are, I mean, you have all these trigger codes. I mean, I'm assuming there's different providers within this.
Correct.
So if we're seeing different providers for different things, is that something that instead of a daily rate?
My guess is the state will stick with that daily rate for at least a 4 to 6 year period and then reevaluate and see if that makes the most sense for organizations or if we move to a different model. There's multiple payment models related to a prospective payment. This is called a prospective payment model. There's multiple ways to do that. You can do it daily, you can do it monthly, you can do it by service. And I think the state's probably going to stick with this daily rate until everybody is certified as a CCBHC, see how it works, and then consider maybe a change in that payment model.
Okay. Well, if there's any way that we could, I mean, I know it's in a while, but if there's any way that we can help kind of push some of that, I think that would be huge to be able to take it from $245 a day to $245 per service that they're receiving. So, thank you.
Thank you.
Okay, any other questions? I'm saying, Michelle, thank you very
Thank
much
you.
for the briefing. I enjoyed it.
Okay, thank you.
Mr. Manager, what do you have?
That's all we have, so you have 2 hours back on your schedule.
Seriously.
Mercy. I brought a whole diet dew in and only got part of it.
Lindsay's looking a little confused.
Thank you. Well, I guess we're adjourned then. Thank you.
Health and Substance Abuse Coalition request.
That's going to come at the task force. Okay, we're done.